Thank you, Ajay. And uh, diabetic macular edema is a problem which I think a lot of people are facing, and that's why you can see the surge in the crowd. And diabetic retinopathy itself is a major. India is now the diabetic capital of the world. Increasing figures of diabetic retinopathy more and more in this country due to environmental factors, lack of exercise, truncal obesity, as well as genetic factors. Indians are more genetically predisposed to also develop diabetic retinopathy. So I'll be talking about the role of anti-VEGFs and why do we do pharmacotherapy or drug therapy for diabetic macular edema? Because DME happens to be the most frequent cause of visual impairment in DR. We all know that. So it's important to achieve, as Ajay was mentioning, the optimal glycemic control, normalization of BP, lipids. Glycemic control will be the glycosylated hemoglobin and the renal and the cardiac status. But these will probably stabilize the vision but not improve the vision. So therefore the goal would be to improve the vision as far as possible. Laser stays the gold standard for that. However, laser improves again, stabilizes vision, especially in patients with diffuse DME or even focal to some extent. If it's center involving, there's a big problem about that. And this lecture aims to discuss the various drug technologies for treatment of DME, which is generally center involving and involves the use of anti-VEGFs also. So I'll tell you about the anti-VEGFs. The first that we should know what are the types of DME, and OCT has been talked about in various retina sessions, and OCT happens to be a very important tool for detecting the DME, and you can have either a spongy DME which may respond to laser only, the cystoid DME where you have cystic patterns, or you have a traction like this, vitreomacular traction, and there is a kind of a cases, these kind of cases respond to surgery, or you have a traction detachment, and these next two pictures show you a serous detachment of the macula with cystic fluid with hard exudates. These kind of patients respond very well to anti-VEGF therapy. And the last picture shows you atrophic retina with a very thick fibrotic ERM. These patients, you may peel off the ERM, but seeing the underlying retina, you will see it's very atrophic, so the visual acuity recovery will not be so encouraging. Hence, you have to decide based on OCT what is the type of picture you see in the initial phase. In the first instance, there is no harm doing the fluorescein. Do not condemn fluorescein. It's also gold standard, as not only for the baseline status, for knowing the state of the RP and the state of the vascular perfusion, the FAS, the foveal vascular zone, is very important. To differentiate between focal and diffuse edema, there is a level 4 AAO guideline that says that focal versus diffuse can be known only by this. So because if you got a ischemic maculopathy as shown in this picture, then you might probably avoid anti-VEGFs also, because there are conflicting reports more towards the side that which they say anti-VEGFs may affect the vision, and fluorescein of course may stay as a research tool. Now this is the OCT which carefully tells you a section cut along the 1 and 12 o'clock position, and both sections taken of the right and left eye, and you can see the amount of center involving cystic DME over here. This kind of cystic DME center involving should never be subjected to any laser treatment or medical treatment. Of course always goes hand in hand, but this kind of patient would definitely require center involving DME is mentioned by Ajay, and so we have to do the anti-VEGF treatment. So we just want to tell you a word about wide field imaging, which is about 200 degree, though it's being covered by Dr. Vishali Gupta. So it's just that we do it also, and we find that a lot of ischemia in the periphery comes up. So these kind of patients, not only the PDR doesn't respond, but even the DME doesn't respond. And we have these patients of chronic neovascularization, heavy lasers being done, but the periphery shows ischemia, and these patients require therapy. So coming to 3 or 4 very important trials before I come to the anti-VEGF per se directly. These are all drug related or the anti-VEGF related. This is the drcr.net trial, which is a protocol I, which is very important, which showed that if you give ranibizumab with early laser within 10 to 15 days or deferred at 6 months, they found that deferred did better. But the 5-year results showed that the early versus deferred didn't have any difference. In fact, the deferred required more injections. So they said combination therapy is very useful, and you should give the laser after 7 to 10 days or after 6 weeks, after 6 months. But ranibizumab is the drug which has to be common to both in the protocol I. I'll leave the rest, and then I'll just come on to the bevacizumab trial, which was also done, showed 1.25 milligram Avastin, which is now being hotly talked about to be more effective than focal laser in DME. Aflibercept has recently entered the armamentarium or anti-VEGF armamentarium. You have the Da Vinci Vivid Vista trial. The View 1, View 2 are the AMD trials, so don't confuse it with them. The Vivid Vista showed that if the intravitreal injection of aflibercept given every 4 weeks or every 8 weeks, 2 milligrams, not 0.5 milligrams. They studied 0.5 and 2. So they kind of gave a super normal dose, because we attended their Delhi study group, this thing. And so 2 milligrams is a potent dose. They found that every 8 weeks it was about the same result. But the 0.5 milligram, they showed the results were inferior to ranibizumab, definitely inferior. So they took off the 0.5 and said we'll concentrate on a 2 milligram. It's something like ranibizumab shifting from 0.3 to 0.5 milligram, which they give now, to suddenly to 2 milligrams. So I don't know about that, but this is there. So this is just to show you a patient who had a complicated kind of a center involving DME with hard exudate, cystic edema, and a serous detachment, but he's got a little bit of membrane also. These patients, you don't peel off membranes initially, you first give the anti-VEGF. And post anti-VEGF, the patient has recovered to some extent, the serous detachment has gone down. So this is to show you what are the strengths of the various anti-VEGFs in DME. Ranibizumab has a low molecular weight, better retinal penetrations of 48 kilodalton molecular weight. It's less antigenic, it's genetically engineered. It has a very short half-life, hence there are very, very few side effects. Bevacizumab is equal in efficacy to ranibizumab. This is a very important point to consider. From our point of view, an economical systemic half-life is 20 days, but the studies have shown it to be quite effective, the protocol T. Little bit of adverse events have been shown to be more, but they're comparable. Now, VEGF trap eye or aflibercept or Eylea, as you can call it, is a powerful VEGF binding. It receptor binds. It's 140 times potent as compared to ranibizumab. Peak efficacy is similar. It inhibits VEGF A, B, all the VEGF isoforms and the placental growth factor. It's a potent inhibitor. Now, they say bi-monthly dosing, but most of the studies recently which I fished out last year and this year, including 2016, showed that the final outcomes at 1 year were showing the visual acuity as well as the OCT morphological improvement was same as with ranibizumab versus VEGF trap eye or Eylea at 1 year end. And the German watchdog, which is equivalent to NICE, showed clearly that Eylea had no advantages over ranibizumab, they said. Though Bayer is a German company, but they don't go by other things than the scientific data. So the safety profile is an issue because this has also been discussed that being so potent, it has a longer half-life, comes into the systemic circulation for people more than 70 or 80 years of age. The ATEs are more, the arterial thromboembolic events may be more. So it's preferable at this stage to probably start with ranibizumab as initial drug therapy or bevacizumab as initial drug therapy. Only if there is a refractory edema, then that is after 3 to 6 injections. There's a very vague definition. Here it's a 3-month, 3 injection definition. But also that you've tried laser, steroid, and then it doesn't work, then you can switch to Eylea or as an option to see if it works. So therefore, as a primary treatment modality, we've also recommended to the government of India that Eylea should not be recommended. It should be only given in cases of refractory DME after 3 injections. And if the patient responds after 3 injections, 3 months, then he does not shift to Eylea, and then the government will not be giving that drug to him. So I'll just quickly go on, and these are the, before ending, these are the various other anti-VEGF drugs, the mTOR inhibitors, everolimus, sirolimus, you must have heard of sirolimus. All these are drug-eluting stents are also used, and they are also used for subconjunctival dose and probably not intravitreal, so they are lipid bound. And then you have tyrosine kinase inhibitors which will come in, but all these are in the trial and the studies going on which have not been cleared. So new in DME DR is that the DRC protocol T, I already didn't tell you right now, the comparison of ranibizumab, bevacizumab. The T showed initial 52 showed slightly better gain in the Eylea group, especially nice with poorer initial visual acuity. Outcomes similar if initial visual acuity is better. Now this is all open to question and it's difficult to say. There's another protocol S which says that Lucentis is non-inferior to Lucentis plus PRP for visual acuity at 2 years. So what they say is that if you give Lucentis along with PRP, the results are much better. This is recently come out the protocol S. So I'll leave this, I think we already know about it. You just want to say a laser anti-VEGF is not a one-time procedure. Regular lifelong clinical evaluation, FA, OCT is required. Thank you so much.